So, when you think about genetics of myeloma, we really focus initially. We're going to talk about mutations in a little bit. I'll talk about the genetic features, which is generally the translocations. Those translocations are available or present from the get-go. And if you don't have a certain translocation and you pick it up later on, it may just be that you did not have enough cells with those translocations. And the typical translocations that we look for on fluorescent in situ hybridization techniques is you look for most of the translocations happen around chromosome 14. So you have the 1114 translocation, the 414, 1416, and the 1420. These are sort of the translocations. And the reason it's around chromosome 14, that's where the switch happens, the immunoglobulin switch region, and that's where most of these translocations are focused. Now, we have drugs which can impact outcomes in patients with myeloma with specific translocations. So 1114 translocation, for example, is associated with cyclin D overexpression, and we are beginning to appreciate that drugs like venetoclax, when combined with bortezomib, actually do extremely well in patients who have the 1114 translocation because this group of patients tends to be more BCL2 dependent. Venetoclax is a BCL2 inhibitor. And that's why understanding the genetics of a patient's myeloma is really important. Some of the others that I've mentioned, the 414, 1416, 1420, are considered high risk. We have another deletion 17p or the 17p or the p53 mutation, which tends to cause or confer a poor prognosis for patients or a higher risk prognosis for patients with myeloma. Why is it important to understand this? Well, over the last few years, we've realized that if these patients are treated with a proteasome inhibitor like bortezomib or carfilzomib, you can overcome some of the negative prognostic factors of these genetic abnormalities. So it's really important to understand this at the outset. The other important thing I will say is even at the time of relapse, it is important to look for translocations. You may have missed them at the time of diagnosis. Certainly, mutations are something which are picked up along the way. So you may not have a p53 mutation at the get-go, but you might acquire it over time. And more than the p53 mutation, when it comes to mutations, you're looking at other mutations. And the other mutations, which are quite common in the context of myeloma, include mutations like the BRAF mutation. It occurs in about 6 or 7% of people. And then there is others such as the NRAS and the KRAS mutations. Now, some of our solid tumor oncologists are quite used to these mutations. And in the context of myeloma, it sort of sits between heme malignancies and solid tumors where it does harbor these. And the incidence of NRAS and KRAS mutations is not trivial. It's about 20 and 20% each. So collectively, it's about 40% of patients. And these are mutations which are acquired over time, right? They come at relapse and second relapse. Why is it important? Well, we have drugs which we can use to target these mutations. So you have BRAF inhibitors, which are in clinical trials. We have MEK inhibitors, and we have trials where we're combining BRAF and MEK inhibitors. And I think the more you understand about the genetic landscape of a patient's myeloma, the more options you will have for treatment. For example, through the Multiple Myeloma Research Consortium, now we have a clinical trial which is called the MyDrug clinical trial setup. And what this clinical trial setup does is looks for these specific mutations, and based on your mutation or whatever mutation that specific patient has, you're then triaged to that specific inhibitor on this MyDrug platform. So that really is the future of how we should be treating patients. And that's why I think understanding the mutational landscape of a patient is really important.